Okay. Well, welcome everybody. We're excited you could join us today for our special presentation by Dr. Atur Singhi of UPMC. Before we get into that, I'd like to provide a brief overview of PMP PALS if you're new to us or don't come on our group support calls consistently. So, my name is Adele Jason. I am the president of PMP PALS. I'm a volunteer and a survivor. Uh, with my slides here, PMP PALS is the world's oldest global volunteer run organization that gives hope to patients and caregivers with appendix cancer and related conditions like PMP. Uh, some of our disclaimers for our Zoom calls, we provide these forums to provide patient fellowship and support. We are not licensed medical providers, so we are not providing medical advice. Patients must seek their own licensed physicians who are qualified to develop and provide your own individualized treatment plans. We do have a presentation today, so sometimes the information or data can be a little scary, but just know that each case is different, each patient is different, and that doesn't necessarily mean what is being presented is you. By participating in our Zoom call, that means your identity and health condition might be shared. You can hide your image, change your name, but we can't guarantee anonymity on these calls. We do record these specialist presentations just as information, and by participating, you grant us permission to share your likeness and image. Some of our programs, as a reminder, as I mentioned, are Hope Zoom calls twice a week, Wednesdays at 6 p.m. Eastern and Saturdays at 11 a.m. Eastern are when we provide group support calls. We have a variety of guests from time to time, one today, and we will record that and post that on our website. Also on our programs, two of our most popular programs are our CARD program and our BEAR program, where we provide support, hope, and just messages to patients to let them know we are thinking of them and they are not alone. We're on social media, and in addition to our group mentoring Hope Zoom calls, we provide one-on-one patient support. Also blankets in addition to the bears and the cards, and just with our fellowship, just giving hope and showing pals living life. You can reach us at info@pmppals.net or at our website pmppals.net. We're entirely volunteer run and rely solely on donations. So any support you could give us, especially as we're closing out the year here, would be greatly appreciated. And again, we have hope for you. Please connect with us through any of our channels, and we're glad you're here today. So without any further ado, I am so thrilled to introduce Dr. Atur Singhi, who is a surgical pathologist at UPMC, and he has a lot of depth and expertise in looking at the pathology for what our group deals with. And so I'm going to turn it over to Dr. Singhi.
Thank you, Adele. Let me just share my screen. All right. So, as Adela mentioned, I'm a GI surgical pathologist. I'm also a molecular pathologist, which kind of goes hand in hand when it comes to appendiceal mucinous neoplasms or any cancer of that sort these days. Because to be honest, fundamentally every cancer is a genetic disease itself. Now, when I was asked to give this presentation, I have to be honest with you, I wasn't sure what to expect as a pathologist. Pathologists, for the most part, we're kind of those physicians that are in the back area that are looking under the microscope for the most part, or in this case, this day and age, more of digital images overall on a computer, as well as looking at molecular sequencing. But it's hard to understand sometimes the patient side and some of the questions that could arise. But I'm certainly understanding that from just talking with a few of you this morning that, and I think that one of the challenges will be in this presentation itself is understanding the nomenclature used in the pathology report, understanding how that implicates or what are the implications of that pathology report. And I know that there's going to be a lot of questions. There are going to be things that I can't cover, and there are things that I will cover. But I'm always open to questions, happy to have a discussion afterwards. I'm trying to leave some time at the end. Some of this also will be a little repetitive, maybe from the other presentations, so I apologize for that. But I did want to try to kind of give a basic covering of what we're dealing with in pathology and understanding that we're trying to convey to both clinicians and to patients. And so, in the brief time I have today, I'd like to go through a few objectives. Obviously, one of the largest or one of the biggest focus areas for appendiceal neoplasms is the appendiceal mucinous neoplasms, as well as pseudomyxoma peritonei as a kind of a pathologic consequence. I will be talking about goblet cell adenocarcinomas as well, so that will be later in the talk, but certainly primarily appendiceal mucinous neoplasms just because of its higher prevalence. And in fact, this is the first time I'm giving a talk, and I wasn't 100% sure on the audience. I think that certain things are challenging to understand when it comes to a pathology report, and that includes tumor grading and staging, the role of molecular testing, which is really increasing now. Almost everybody gets molecular testing, and what does that mean? Prognostically, therapeutically, and then what do you have to understand as a patient when it comes to seeing those molecular reports? Because I know that those can be quite complicated and several pages, maybe 10, 20 pages long sometimes. And then what does that give you as far as options like treatment modalities and then follow up thereafter? And that could be including CRS HIPEC. But I think it's best to start first of all is what is the appendix? And when I put this presentation together, I didn't want to create a point where it's like an autopsies. This is not CSI. This isn't going to be where you see blood and guts everywhere. I wanted to make it simplified, and I wanted just to talk about the general thought process that we have as pathologists. If I had to just say teach a medical student about what is the appendix, what is the anatomy, etc. And I think that's where you start with, honestly, in this, honestly, from an educational point of view, you're going to see a lot of cartoons trying to depicting what we're looking for and what we're seeing. And for the most part, an appendix, as most people here probably already know about that, is that it's really a blind pouch. It's for the, I guess probably to say it's just a vestigiage of the large intestines. It's in the right lower quadrant. It's hooked up to a portion of your large bowel. And we're still looking at trying to understand what the actual the function of an appendix is, but that's really still a bit of a debate. But it is not really considered essential for digestion or overall health. However, it does contain colonic epithelium, so it does contain epithelium that's associated in continuity with your large bowel and your bowel itself, your GI tract. It has a lot of lymphoid material in there, meaning that it has a huge encompassment of the immune cells. Remember that your immune cells, about 80% of your immune cells are actually in your GI tract, and there's a lot of that in your appendix. But being a blind pouch, it's also vulnerable to certain diseases, meaning that, remember, think of this as a pipe that has an end that's been blocked off. And when you close up the other opening, things can happen and things can go awry. Things can arise out of this organ itself. One of the most common pathologies as a pathologist that I see almost on a daily basis is something called acute appendicitis. And those patients that are presenting with neoplasms of the appendix or even inflammatory conditions all pretty much report the same signs and symptoms associated with acute appendicitis. But to a pathologist, to a surgeon, really what changes in the acute appendicitis or the acute appendix itself is that the overall organ itself becomes red, it becomes inflamed. And remember, I said there's a lot of inflammatory tissue there. It becomes very hypervascularized. And that's for us to understand what is wrong with the appendix. If a surgeon sees that intraoperatively, they know that there's something going on with the appendix, and that's where they will remove that piece of organ and then send it to a pathologist where we will evaluate this tube and it's the margin, which is on the left side where it's associated with the colon itself, and then understand what's going on the underlying pathology that could be giving rise to that acute appendicitis, which can be a lot of different etiologies. Sometimes it could be a fecalith plugging the system itself, something plugging the pipe. It could be an infectious disease, an organism. It can also be, unfortunately, a neoplasm, and we'll talk about a number of the neoplasms that come to presentation. But for the most part, I would say that one of the most common neoplasms of the appendix is what we call the appendiceal mucinous neoplasm, or APN. AMN, excuse me. And appendiceal mucinous neoplasms have had many names throughout actually probably a few decades, and they've been called various different things, but we're all trying to speak the same language. The only reason that the nomenclature or the way we call them has changed over time is that we're starting to learn more and more about these neoplasms. Because of the fact that they're so rare, it becomes a little challenging to understand and study as a group, as a basically society when it comes to clinical teams and research overall. But appendiceal mucinous neoplasms, as the name implies, is a mucinous lesion or neoplasm that's arising out of the appendix. And it creates this jelly-like substance that basically engorges. It increases this pipe that becomes very, honestly, pressurized. And one of the things about the appendix is it's not really conducive to a ton of pressure. And what happens when that pressure builds up is unfortunately it perforates, it blows. Just like a pipe. When that pipe closes off, it will have a lot of pressure and it has to relieve that pressure. And that's what happens when you have pseudomyxoma peritoniae. When that appendiceal mucinous neoplasm, and we'll talk about the various grades and types of appendiceal mucinous neoplasms a little later, but what happens is that pipe unfortunately bursts, and that's which leads to that neoplasm leaving the appendix, colonizing the surface of the appendix, and then eventually disseminating to other sites, not just the appendix or around the appendix itself in the GI tract, but to other areas of the GI tract that can go as high as up to the diaphragm, to the stomach, and even as low as down to the rectum and to the anus. And so I know this is a very generalized terminology, but we are trying to consolidate some of that nomenclature to make it more simpler so that we're all speaking the same language. And what we know now is that when it's disseminated and it's actually implanted into other areas, and that's predominantly mucin when it comes to appendiceal mucinous neoplasms, that disseminated disease is known as pseudomyxoma peritoniae, or PMP. But where does this all start? Well, to be honest, it's a microscopic disease first. I mean, we've talked about the whole organ, the outside in approach is probably best. And again, I don't want to get to the point where I'm trying to talk about things that might go over people's head or be minutia, but I really want to focus on the true pathology of the appendix. And the appendix normally is epithelium, as all of our organs are lined. They're lined by a single layer of cells that we call epithelium. And for the most part, and his normal histology at the top shows what test tubes of that epithelium that they look like, where they kind of go undulating up and down, up and down. Now, to help make that a little easier, I try to make a cartoon of what that epithelium looks like in that singular epithelium. And it has crypts at the bottom. It has what we call lamina propria that supports those crypts. And then there's a muscle layer. The muscle layer of the appendix is a single layer of muscle that really kind of holds everything in place, that keeps things firm, keeps things moving. Basically, you can think of it as the same muscles as you have in your arm that really help kind of support as you lift weights or lift boxes, heavy boxes, especially now with presence. But when it comes to neoplasms that arise there, there's a change in that epithelium. And we know now that these neoplasms, these appendiceal mucinous neoplasms, are actually arising out of that single layer of epithelium. And fundamentally, as I mentioned, neoplasms or cancers are a genetic disease. There's a change in the genes that are associated with these neoplasms. And I'll talk about that a little later. But that change in those genes or the acquisition of these gene mutations results in the epithelium changing its histology, changing what I see under the microscope. The cells, the nuclei change overall, and that creates a change in the overall architecture that's very broad. One of which is you lose certain aspects. You lose the crypts of the epithelium of the appendix. You lose the lamina propria of the appendix, the supporting structures. For some reason, this neoplasm then becomes juxtaposed to the muscle layer. Literally, it's destroyed all of the surrounding infrastructure around it, and now it's really pushing against the muscle layer. And it's developing lots and lots of mucin in the lumen of the appendix, as you can see here, where that mucin starts to increase. And it starts to then build up pressure. This neoplasm has lots and lots of mucin production, and then it starts to unfortunately clog up the pipe. It becomes very thick and tenacious. Now, these neoplasms, when they first start out, are what we call low-grade appendiceal mucinous neoplasms. They haven't invaded the appendix. They're just lining the epithelium. There's just a change in the epithelial lining. But for the most part, they are a non-invasive neoplasm. Now, there is something called a Hammond or a high-grade appendiceal mucinous neoplasm, and that's really strictly based on morphology. They're still non-invasive. They still adhere to the epithelium of the appendix, but their nuclear morphology, their architectural morphology becomes much, much more complex. I don't have a picture of there because I wasn't absolutely sure I was going to be talking about Hammonds, but I know that a number of people had questions about it. But Hammonds themselves are high-grade appendiceal mucinous neoplasms. You can think of them as a much more complex and uglier looking neoplasm, but not invading the appendix. Now, that being said, when I mean invading versus a ruptured appendix is two very different things. And we'll talk about that in a second. But what happens as we have this appendix that's producing this neoplasm, that's producing a lot of mucin, is again this increasing pressure, which is a key factor in an eventual rupture or potential rupture, I should say, of the appendix. And again, that appendix is really a vulnerable organ. It's narrow, it has a blind lumen, it's going to be susceptible to, unfortunately, this pressure buildup. And the mucin that's produced by these neoplasms is very thick. It doesn't have an easy way to escape into the regular colon itself. So it just builds up there, and that can facilitate that neoplasm as well to get out of the appendix through a perforation. Now, if you had to take the whole organ again, taking a cross section. So basically, let's say I bread loafed the appendix itself, and then I looked at that slice of bread en face, looking at the normal appendix. On the left is what we would see, the epithelium, the lamina propria supporting the epithelium, and then you have that muscle pink layer. When it happens, when we have lamin or an appendiceal mucinous neoplasm that's strictly focused on the epithelium, is that mucin layer starts to engulf and destroy all that lamina propria, and then it starts to really make a ton of mucin, narrowing the lumen, as you would expect, and then eventually causing that pressure to build up. The muscle itself becomes very thin as well. And as you can imagine, as that muscle becomes thinner and thinner, that barrier for that neoplasm to leave the appendix becomes very thin and thin overall as well. And then unfortunately, that appendix becomes vulnerable to rupture itself. Now, when that appendix ruptures, unfortunately, if let's say you have a low-grade appendiceal mucinous neoplasm, that neoplasm itself then has free range to leave the appendix, unfortunately. Now, the first step often is that the epithelium is then swimming in this mucin, and then it lines the outside cavity of the appendix itself. So staying confined mostly to the right side of your abdomen itself, your right lower side. And that's going to be important when a surgeon talks about the peritoneal cancer, or basically the PCI score, I should say, overall, and where it is in the abdominal cavity. And that'll be important also when we talk about staging of these neoplasms. Is it restricted to the right abdominal cavity, right lower abdominal cavity, or has it then implanted outward? Really, when it implants outward, where the mucin or the epithelium and mucin have implanted distantly away from the appendix, going to maybe like the small intestine, going to the stomach, etc., that's what we call dissemination, or basically PMP, pseudomyxoma peritonei, and that peritoneal carcinomatosis as well when we talk about adenocarcinomas. And so for that most part, that's where we're talking about where that neoplasm decides to move on after rupturing and then implant it. Unfortunately, remember these are thick mucin deposits, so they go by gravity and flow, and then they stick to everything. Unfortunately, it's such a thick mucin that it's very sticky. If you put it between your fingers, it's actually hard to separate your fingers because that mucin is so thick. And that's how you can imagine how these deposits kind of actually adhere to the organs, and why a surgeon has to go in and resect and really remove portions of organs when they're dealing with CRS or cytoreductive surgery, and why chemotherapy is so important, because these are very microscopic neoplasms making tons and tons of mucin that is sticking to everything. Now, that mucin characterization and appendiceal neoplasms, and you'll see this in your pathology reports, so often sometimes it says acellular versus cellular, meaning acellular refers to that there's this tons of extracellular mucin pools, but there's no malignant cells identified. The problem with that description, though, is that a pathologist doesn't submit the entire mucin pool. We try to distinguish that there's mucin present versus not mucin present, and that's our primary role here when it comes to PMP. And that's the ability to say, okay, there was mucin here. There's likely neoplastic cells there. It's just that they're really hard to find because, as I mentioned before, these neoplastic cells are making tons and tons of mucin. And it suggests that the neoplastic cells are there. It's just that we can't see them microscopically because there's just so few cells. But when there are cells there, that is a bit of a poor prognostic finding. That means that there's a lot of cells that are growing on that organ that have disseminated outward. And that's where we get very concerned. Now, one thing that can happen very frequently, not very frequently, but I should say not infrequently, is that these neoplasms, when they're low grade and they've perfed off, they can sometimes transform to what we call adenocarcinoma. Now, I talked about Hammonds. Hammonds are basically high-grade appendiceal mucinous neoplasms that have architectural complexity, nuclear abnormalities. They are thought to be a genetic kind of progression, but they're still confined to the appendix, and that they're non-invasive overall. But when an adenocarcinoma occurs, it has transitioned differently. It has now become an invasive disease process, meaning that, remember, we talk about these implants. You have to think of these implants as something that's sitting on the surface of the organ itself. So let's say the surface of the stomach, the outward surface of the stomach, or the outward surface of the colon. But once it becomes an adenocarcinoma, it not only sits at the surface, but now it has that ability to invade that organ. And that's where it gets very deep. And that's one of the reasons why it becomes even more challenging of a disease, a harder disease to treat when it's an adenocarcinoma. And often that's another reason for an oncologist to get involved and to give chemotherapy, and that being intravascular. So you basically then get hooked up to a pump and you often get chemotherapy itself because now you're treating a disease that's not just on the surface, but also in the organs themselves, in your body, invading into your body. And that's where you need extra treatment overall, where it can attack the cancer intravascularly within the organ going outward. So I want to review some of these. I know these are very hard terminologies to understand, and it can be actually very confusing to read on the report. But I would say within actually 2020 to present for the last 5 years, we as pathologists have been trying to conform to distinct nomenclature. And that's where we started with the grading process. We've all agreed that we need to make it easier for our clinicians, our physicians to understand. And so we often start with grade. So grade 1, 2 versus grade 3. Now, the problem, however, is as you assign different nomenclature to things, we want to make sure people understand the history behind that nomenclature and that what it represents. And so when we talk about grade 1 neoplasm or appendiceal mucinous neoplasms, those are your low-grade appendiceal mucinous neoplasms, lamin. Unfortunately, there's not a great Hammond etiology or basically grading system here because they're so rare, they're so distinct. We usually don't grade Hammonds altogether. We often just call them high-grade appendiceal mucinous neoplasms, not really assigning a grade. But you can often think of the Hammonds, unfortunately, being more of a grade 2, grade 3 neoplasm, and we'll talk a second about those neoplasms. But what low-grade appendiceal mucinous neoplasms are is very similar to what I've already described. They're, for the most part, a non-invasive neoplasm that often are in the appendix or have perforated and now disseminated to other sites. But they're a non-invasive neoplasm. They have, to a pathologist microscopically, they can have some mitotic activity, meaning that they can be dividing. The nuclei are charged to start proliferating. But for the most part, what these neoplasms are characterized by is tons and tons of mucin with very little tumor cells. You almost wonder how can such a neoplasm with so few tumor cells be such a big of a problem, and it's because of that mucin that just sticks to everything. Treatment is often localized if that low-grade appendiceal mucinous neoplasm has not perforated. That's a great finding. That's why when a pathology report, one of the things I tell our clinicians when they're getting a report from outside institutions, see if the pathologist commented on the appendix. Was it received intact? Was there any rupture? Was there any perforation? Were there any holes in the appendix that could have given this neoplasm the ability to leave the appendix? Is there maybe mucin on the outside surface of the appendix? because that's also a key that the appendiceal neoplasm itself has gotten the ability to leave the appendix itself, because maybe there was a micro rupture or a perforation that just couldn't be seen with the naked eye, but somehow got there microscopically, because that'll have ramifications on subsequent treatment when it comes to CRS and potentially HIPEC overall. The grade, again, is all based on microscopically. There is no other way of grading other than looking under the microscope. A surgeon, an oncologist cannot determine grade based on just looking at really the disease process and the intraoperatively. They have to send something to a pathologist in order for the neoplasm to be graded. Now, unfortunately, lamins can progress, and those lamins can progress into what we call a grade 2 neoplasm or an adenocarcinoma. An adenocarcinoma is the terminology was adopted because we have lots of different types of adenocarcinomas that occur in the GI tract. In this case, it's a mucinous adenocarcinoma of the appendix. Most adenocarcinomas that are mucinous in the GI tract, I would say, are appendiceal origin. However, we can have mucinous adenocarcinomas arising out of the colon. We can have mucinous adenocarcinomas arising out of small intestine and stomach. But the majority, almost always, when it comes to the right side of your abdominal cavity, when there's a neoplasm there, is more than often arising out of the appendix itself. It's a very distinct neoplasm overall. And these neoplasms are graded based on, again, the morphology. A pathologist looking under a microscope, seeing, first of all, is there invasion into the surrounding muscle layer, let's say, of the appendix. And in here, the arrows are showing a true histology of a patient's appendiceal neoplasm, where you see these little glands filtering downward and eventually invading throughout the appendiceal wall. And that's not a low-grade process anymore, where they're invading, creating desmoplasia, basically creating an environment conducive for them to continue to invade. And that's unfortunately a moderately differentiated adenocarcinoma, again, based on the pathology and microscopically. Now, the growth and behavior of these neoplasms is very different from low-grade appendiceal mucinous neoplasms, as well as you would expect the prognosis. These are, again, neoplasms that can not only invade the appendix, but invade other organ sites if they have peritonealized or they have gone to another site. And these are, when they are in the peritoneal site, is what we call peritoneal carcinomatosis. We often don't say peritoneal carcinomatosis when it's a low-grade dissemination, but when it's an adenocarcinoma, or at least grade 2, and this basically implanted in other areas and invading those areas, that is what we call peritoneal carcinomatosis, unfortunately. Now, you'll see the term peritoneal carcinomatosis referred to in many ways by radiologists, by clinicians, but when it comes to pathologists, we're very pure. If it's not invading, it's not true carcinomatosis. If it's not an adenocarcinoma, then for the most part, just a low-grade appendiceal mucinous neoplasm, it's really dissemination of disease and implantation, but no invasion into the organ itself. But unfortunately, an adenocarcinoma is a concern. It has a higher cellular typia, higher mitotic activity, has greater malignant potential, meaning that it has a higher unfortunate ability to be associated with poor prognosis and to cause problems in the long run as it starts to destroy the organs that it implants into, unfortunately. Now, there is the last grade, and that's a 3-grade system again. It's grade 3, and that's called poorly differentiated mucinous adenocarcinoma. Unfortunately, these neoplasms are extremely aggressive, and they're characterized by a distinct morphology in what we call cingulate ring cells. I try to depict a cartoon version of that at the top, but truly under the microscope, these are what we call cingulate rings, meaning what happens is the cells have changed significantly. First of all, they're little single cells that where the cytoplasm has become engulfed and basically infused with mucin, pushing the nucleus off to the side such that it looks like a ring, like literally a ring that you could put on your finger on a cross section, and hence the name cingulate ring cells. It was really named after really an old age kind of ring that you would put on your ring where you could have a seal. And that really represents what we see under microscopically. Now, there can be lots of variation to a pathologist of what cingulate ring cells are, but the truest form of these neoplasms, unfortunately, is a grade 3 neoplasm. Now, these are thought to morph from your moderately differentiated. So there is a kind of a progression model that's implied with grade 1 versus grade 2 versus grade 3, that most cingulate ring cell adenocarcinomas of the appendix are really arising out of a moderately differentiated neoplasm, a moderately differentiated adeno, and then a moderately differentiated adeno is arising out of a lamin. Hammond, you can think of as just coming in between the lamin and the adenocarcinoma from a simplicity point of view when it comes to that progression model. Unfortunately, these are one of the most aggressive mucinous neoplasms of the appendix. They often destroy a lot of areas around the appendix and localized also in destroying a lot of the colon and then the sites that it involves. These are very hard to see microscopically. Often the surgeons have a hard time identifying them macroscopically as well because you can envision these are just single cells floating in mucin, but sometimes that mucin can get poor, where that mucin switch, where they produce lots and lots of mucin, has switched off. And now you're forming little single cells that are just invading, unfortunately, different organ sites and causing problems. These are where your surgeon wants to be extremely aggressive with both CRS and HIPEC, in addition, excuse me, with systemic chemotherapy to really target that microscopic disease that's invading into multiple sites more often and hopefully prevent recurrence. Now, I've talked about this disease progression model, and I've started off my conversation that fundamentally this is a genetic disease. And I truly think that's true in what's going on. And actually, the grading system itself kind of follows that genetic disease progression. Now, many of you have probably seen your pathology reports and seen that the results of molecular testing were performed. And one of the most common mutations in appendiceal mucinous neoplasms is the identification of KRAS and GNAS mutations overall. KRAS and GNAS mutations are thought to be the initiating gene alteration. So you can think of it as you have many genes in your body. I mean, you share chromosomes from your mom and your dad. You have two copies. But one gene in particular, KRAS or GNAS, has mutated and it has become to the point where one of those genes has become very hyperactive. And that hyperactivity then drives the neoplasm to change. And these occurs pretty much at the lamin stage. What we know about GNAS right now is that it's actually one of the most common genes associated with appendiceal mucinous neoplasms. And maybe not surprising, GNAS in a mouse model or an animal model, when you turn it on, it creates a neoplasm that has tons and tons of mucin. So that justifies us understanding that that is true driver, meaning that it is a gene that is truly driving this disease process. And something that we're all trying to understand is how does GNAS do that in creating all this mucin and then driving this neoplasm overall? Because if we can shut down the initiating gene factors, maybe we can shut down the neoplasm as a whole. Now, if it starts at low grade, it's going to progress to moderately differentiated as grade 2. And that multi-step progression model is thought to occur with the acquisition of additional genomic alterations. Those additional gene alterations that you may see in your report if you have an appendiceal mucinous adenocarcinoma are P53, SMAD4, PIK3CA, to name a few. There can be other genes. Some have been linked to ATM, some are what we call CDKN2A or P16. These are all additional alterations that have been associated with adenocarcinomas, not only of the appendix, but of other sites. You can see this in lung cancers. You can see these P53 SMAD4 alterations in pancreatic cancer. You can see it in lots of different neoplasms, whether it's part of the GI tract or digestive system or outside the digestive system. These are common genes fundamentally associated with cancer, and unfortunately, they occur also in these adenocarcinomas of the appendix. So again, the initiating factors are KRAS and GNAS as lamin. But then when these neoplasms transition to an adenocarcinoma, grade 2 and grade 3, they then acquire additional genetic alterations. It's basically supporting the idea that this accumulation of genetic alterations drives the pathogenesis of appendiceal mucinous neoplasms that correlates with grade, and why we've revised a lot of the nomenclature, a lot of the grading process to reflect the underlying biology that we're starting to learn, continue to learn about these neoplasms overall. Now, I think that there's many ways to diagnose lamin. There's many ways to diagnose adenocarcinomas of the appendix, but the honest truth is it's all underlying on the pathologist, unfortunately. And that's my role. Now, I would be remiss to say that all pathology reports are the same. You will certainly see different nomenclature being used. And again, it has to do with the fact that these neoplasms are rare. If you're not a pathologist that's keeping up to date on nomenclature, you will call it something different based on your prior training or based on some of the older literature. But we're all trying to speak the same language. When we created these grading schemes, we wanted to make sure that the language stays continuous, that people understand what was previously reported so we can correlate that data when it comes to patients and treatment as we go forward. And so there's many different names to some of these lesions. Lamin used to be called low-grade adenocarcinomas. Hammond's used to be called high-grade adenocarcinomas. And so we want to make sure that those nomenclatures still preserved today, but we also can continue to evolve in our understanding and basically synoptic reporting of these neoplasms. But that being said, the true diagnosis itself is truly based on pathology and obtaining a biopsy. A radiologist cannot predict with certainty that a lamin has transformed to an adenocarcinoma. And without that, an appropriate treatment cannot be planned. And unfortunately, that requires a surgeon going in and getting a biopsy sometimes. And that's really important for treatment planning. So delaying that, if a surgeon says, oh, we need to get another specimen to see if your neoplasm has transformed, that is extremely important. I know that a lot of patients want to delay that because they hate having to go in for another procedure. And now even more now post-COVID, it's just scary to go to a hospital, especially during flu season. But it really is important if somebody says that something may have changed in the neoplasm, it's time to get another biopsy after if you're undergoing treatment and the resistance of that treatment is occurring, it is important to understand again if that pathology has changed. Now, we talked a little about different approaches and different treatment modalities a little. When it comes to the pathology, that has a huge impact on what a surgeon like Dr. Ping Peng, who spoke last week, is going to do. So if this is, let's say, a lamin that is confined to the appendix is intact, hasn't been ruptured, there's no mucin outside of the appendix. The patient is essentially cured, assuming the margin of resection at the appendix is clean. That means that the surgeon does not need to do, let's say, cytoreductive surgery. That doesn't have to go and get an oncologist involved in giving systemic chemo for a potential adenocarcinoma, as long as it remains a lamin and an intact appendix. Those patients have an excellent prognosis. Rarely do they ever present with ever any disease recurrence whatsoever. That being said, that's where the pathology helps tailor the surgery that is going to happen. Now, if it was a higher grade neoplasm, like an adenocarcinoma, that was still confined to the appendix, that is not 100% true. And that's where we're going to look as a pathologist, we're going to look for other prognostic parameters, such as invasion into the vessels, invasion into the nerves. That's going to be key whether the surgeon is going to have to go back and remove more of your bowel, or if an oncologist is going to have to give you chemotherapy. Now, of course, when it comes to HIPEC, no one likes to get HIPEC. HIPEC is a very challenging procedure overall that has its own risks as well as side effects, but also its key benefits when it comes to pseudomyxoma. But I think that is really important to understand the pathology before understanding whether you need to have HIPEC or not. I've gotten that question before. I have a low-grade appendiceal mucinous neoplasm. It's still confined to the appendix. Do I need to get CRS HIPEC right away? No. That appendix, basically that neoplasm itself, remained intact. That is not a surgical procedure anymore at this moment in time, unless there's something concerning based on your clinicians, your radiologists, your surgeons, your oncologists that needs to be evaluated overall. But certainly there are indications for chemotherapy when there is an adenocarcinoma or if there's unresectable disease. Sometimes the disease process is so significant that a surgeon may not send for pathology because they intraoperatively saw the neoplasm, seeing it visually, seeing the amount of disease burden, and you may ask, like, why didn't they send for a pathology report? Unfortunately, sometimes those are cases where it's clear what the pathology is and that the next sign is really continued chemotherapy. And so there can be times where a surgeon, an interventionalist, a radiologist may not have submitted something, and those are those indications. So I wouldn't also be concerned with if pathology from every different site of potential involvement was submitted. or was not submitted, because oftentimes it's just consistent with the disease process that we all understand, and now we all need to tackle it as a team-based approach. Now, things that are important in the pathology report is also the grade and stage itself. And I'll go into a little about that in the pathology report section of this talk in a second. But I think that there are important implications for grade and stage, and that's really surveillance. So after you've gotten your pathology report, that's where a surgeon is going to determine your overall prognosis. Is it a laminin? Is it an adenocarcinoma? Is it confined to the appendix? Did it leave the appendix? And that's really going to tailor how you're evaluated in a personalized approach. I think a lot of patients are questioning, okay, do they need to be really pro-aggressive right now versus not? And I think that's a question that has to be discussed with the surgeon based on that pathology report, because those are the things that the surgeon is able to do, which is really put everything together. That includes not only the pathology, but the tumor monitoring, basically the tumor markers themselves, like CEA, CA125, CA199, that you may see in your blood tests that were being ordered, some of the imaging surveillance, and that actually grade and stage may also impact how often you get surveillance, and then how they deal with potential recurrence issues and detection of those recurrence issues. There are many tests that are coming online from Natera, looking at sequencing from the blood-based sequencing overall, and you may have gotten some of those. But for the most part, your surgeon will be your best advocate in understanding how best to evaluate your disease and a follow-up manner itself. But overall, I think that what we do understand from prognosis and survival outcomes, I don't want to really kind of undermine your surgeons. I think this is something that you need to talk to your oncologist. But what we do know is that generally that low-grade neoplasms are a little more indolent, have excellent prognosis, while high-grade neoplasms are unfortunately more aggressive, leading to lower survival rates. But again, that doesn't mean that there aren't options. And those options, now we're learning more and more about those molecular mutations. We talked about KRAS and GNAS being early alterations and the P53 being a later alterations. But we're also understanding that there are other alterations that may be of use, that might be of importance when it comes to these neoplasms and being able to target these neoplasms. Many of you have heard about HER2, like when it comes to breast cancer. Interestingly enough, some of the technology, some of the therapies that we use for other neoplasms may actually be useful in targeting these neoplasms overall. Talk about that at the end. Now, I want to shift a little gears, just a little to goblet cell adenocarcinoma to give that a little time. I wasn't sure exactly the audience, so I apologize. But I do think it's an important disease process, although rare. It is important to understand that these are distinct neoplasms that can also occur in the appendix, but have a different cell of origin. We talked about the origin of appendiceal mucinous neoplasms arising out of that surface epithelium. But in reality, a goblet cell adenocarcinoma does not arise out of that epithelium, that surface of itself. It arises actually in the wall of the appendix, and it's thought to be stem cell derived. These are primitive cells that somehow give rise to these neoplasms. Unfortunately, we don't really understand these neoplasms at all, I would say. We originally thought these were neuroendocrine neoplasms, but that name changed from goblet cell carcinoid to goblet cell adenocarcinoma because neuroendocrine neoplasms implies that it's an indolent disease when it comes to the appendix. And this is not an indolent disease. Can be an aggressive disease overall, and hence why one of the changes in terminology from carcinoid, which is a German word for neuroendocrine, and then now in English setting now called truly an adenocarcinoma. These neoplasms are characterized by almost what look like ciliate ring cells, like the mucinous appendiceal neoplasms, but they have what we call a clustered growth pattern. And that clustered growth pattern, basically groups of cells, helps me distinguish grade. This is another neoplasm that we try to maintain 3 tiers of grading: grade 1, grade 2, and grade 3. But instead of a progression model, in this time, we don't actually understand anything about the genetics of these neoplasms. We rarely understand anything other than the fact that they sometimes can have P53 mutations. But other than that, we don't know the actual progression model for these neoplasms. We don't know the genetic underpinnings of these neoplasms. And unfortunately, that's where a study needs to occur, where these rare neoplasms, other investigators need to really, in different institutions, need to congregate together to discuss and try to identify what's driving these neoplasms and what we can do to help patients. But grading is based on really clustered growth, where grade 1 neoplasms on the left are where you have lots of little interesting clusters all together in groups, where on grade 3 on the right is where you have sheets of cells, where you've lost that clustered growth pattern. That's usually indicative of a poor prognosis neoplasm, and hence how it was defined as a grade 3 neoplasm, being an aggressive disease overall. Now, as I mentioned, the pathogenesis of these neoplasms is unclear. We don't know where they're coming from. Right now, the current dogma states that it's maybe a stem cell arising maybe out of the crypt or the wall of the appendix. They have potentially a neuroendocrine signature, but they're not neuroendocrine tumors. They're not indolent disease. The true drivers of this aggressive disease process is currently unknown overall. These neoplasms can cause a host of other unfortunate clinical manifestations, but they mimic what we already talked about, which is that acute appendicitis picture, and that's how they most often are identified. Unfortunately, when it comes to surgical intervention, all goblet cell adenocarcinomas need at least a right hemicolectomy. Even if they were confined to the appendix, they inevitably have some perineural invasion. They're invading the nerves. They have some involvement of the veins or the vessels themselves where they've invaded into the appendiceal areas of those specific structures. And hence, you often need to have a right hemicolectomy, meaning that you need to remove not only appendix, but it also has to remove a portion of your right side of your bowel, unfortunately. That is unfortunately because of their aggressive neoplasms, rather regardless of grade. This is very different from grade 1 appendiceal mucinous neoplasms as opposed to grade 1 goblet cell adenocarcinomas, where you not only have to remove the organ, the right side of that organ itself, but you also have to remove drainage, and those are our lymph node dissections. So you might see lymph node reports in your pathology where they've also removed lymph nodes and looked at those lymph nodes because goblet cell adenocarcinomas can often travel into lymph nodes, and that's another way for them to go distantly outside of that appendiceal region to other parts of your body, unfortunately. And that's why often these patients get not only cytoreductive surgery, but HIPEC in addition. Margin assessment is extremely important because these are very microscopic diseases. This is not something where a surgeon can just see grossly at the time intraoperatively and say, oh, the margin is negative. This is where you often will see a frozen section report where the surgeon has gone in and given a portion of that specimen to the pathologist that's there also in the OR to determine whether he has gotten around this neoplasm or not. And that's the unfortunate challenges about goblet cell adenocarcinoma. Things that we deal with when it comes to goblet cell adenocarcinoma is that we are very aggressive with them. And then outcomes and prognosis still remains challenging overall. These neoplasms often are identified in advanced disease. Chemotherapy is often required for goblet cell adenocarcinomas. There is certainly a role for HIPEC. Unfortunately, we still don't know great modes of therapy. These patients often get the same types of therapy that you would give for normal colon cancer or an appendiceal, grade 3 appendiceal neoplasm. Prognosis is unfortunately poor compared to your low-grade appendiceal neoplasms. And again, we're still learning more and more about these. So in the last few minutes that I have, I just wanted to quickly kind of go over again some of the key aspects of your pathology report. And the things that I would like you to do as a patient is that, first of all, you have to be an engaged patient. You can't be somebody that is just happy to take what's been given to you. You really need to understand. You need to understand your biology of the neoplasm, your body itself. And an engaged patient is an informed patient that then can help make medical decisions with your oncologist, with your surgeon, etc. And that's where you're understanding the pathology report, where understanding grade is extremely important. Again, we talked about 3 grades when it comes to mucinous appendiceal neoplasms. We have grade 1, grade 2, and grade 3. Grade 1 is also synonymous with what you might see in your pathology report as a well-differentiated appendiceal mucinous neoplasm, or lamin. There's many names, and that's why I've tried to put grade 1, lamin, well-differentiated. We're all trying to speak the same language, although the language has evolved over time. Grade 2 is considered a moderately differentiated adenocarcinoma, and this progression model where you get to eventually grade 3, which is that cingulate ring cell carcinoma, where these cells are really, truly abnormal, cingulate ring cells overall, very aggressive neoplasm that requires close monitoring. Of course, we also have pseudomyxoma perenniae, which is really based on not on really the grade itself, but really kind of as the neoplasm has left the appendix. But once the neoplasm has left the appendix, we continue to grade because we know that these neoplasms can transition. They can progress molecularly and morphologically. And so a lamin can progress into an adenocarcinoma. So if you see that in your pathology report in the PMP and the deposit, unfortunately has progressed molecularly and unfortunately biologically where it now is invading. And so those are important aspects to think about. Now, another aspect when it comes to just dealing with the primary appendiceal lesion itself, you will see what we do call synoptic pathology reporting. The College of American Pathologists here in the United States, I know this is very different for those that are outside the United States, but I think that for the most part, everyone is kind of conforming to the same ideology, is that what we want to make it as simplistic as possible when it comes to our clinicians and our patients. So we want to use the same standard style of reporting different aspects of the pathology of the appendix. And so we often distinguish these by TNM staging, where we look at tumor, nodes, and metastasis. And we staged based on not only the grade, but the invasion or the involvement of that neoplasm. Remember, lamin is non-invasive, so you'll often see it called TIS, so it's an in situ disease. Nodes, the number of nodes is important because we know that it's prognostic, but sometimes there are no nodes. The appendix is a very clean organ. Sometimes there's only one node there, sometimes there's no nodes. And so you may see that no nodes were identified. That's okay. It's just that in an appendix, sometimes there's just no nodes present. When you have a larger resection, let's say a right hemicolectomy for a goblet cell adenocarcinoma, you should see at least 13 lymph nodes in a pathology report. That is a metric for both surgeons and for pathologists. And then when it comes to metastatic spread, even though there's no actual cancer cells, we talked about the fact of acellular mucin, and that is an important aspect when it comes to metastasis staging. Even though the pathologist may see no cells, if they say that there's acellular mucin, we automatically stage that as metastatic disease because we know that these neoplastic cells are so hard to find. And so hence, and it's impossible for us to really submit the whole metastasis. It would take, honestly, thousands of slides to submit every metastatic deposit, unfortunately. And in the US healthcare system, we're just not set up to do that. Nowhere is actually, if you talk about UK, Canada, etc. But we all understand that something has had to have made that mucin. So it's not that we're trying to take an easy road out. We do know that mucin was produced by something. But probably the most important thing is that if we do see cells there in the peritoneum and involving that, even if it's a low-grade neoplasm with that mucin, we upstage it because we know that the more cells there are there, the more aggressive the disease process is, which makes intuitive sense overall. And then when it spreads outside of your other GI organs to the lung, to the liver, unfortunately, that is associated with a very poor prognosis, where it's almost always systemic disease, and it's gotten there through that, through basically the vasculature. Things that I want you to highlight that you almost will now see on every pathology report, at least in the United States, is your results of molecular testing. I think this is where the biggest challenge is for patients and understanding what do these mutations, these genes mean. It's not well explained out, and I think that's on the part of the pathologist. I will say we're getting better. Our first step is to educate our surgeons or oncologists in understanding what the molecular testing means, and then we're hoping that understanding stems off to the patients. And that's where I say an engaged patient is a very important patient because I want you to ask, what do these mutations mean? What do each mutation mean? What is each gene? How is it involved in the pathology of your tumor? We talked about KRAS and GNAS. If you have a diagnosis of appendiceal mucinous neoplasm that has no KRAS or GNAS, I think that's a question you should ask. Do we have the right diagnosis? Is there something different about your neoplasm? If you have a diagnosis of a KRAS GNAS with a P53, but it's still called a low-grade appendiceal mucinous neoplasm, that's something you need to ask your surgeon. Could this neoplasm already be progressing? It's just that microscopically it doesn't look it, but we also know that the molecular really is the underpinning of the progression of disease. Those are very important questions. In fact, things that are becoming even more important are understanding, are there actionable molecular targets when it comes to either your appendiceal mucinous neoplasm or your goblet cell adenocarcinoma? Things that you will see in the molecular report, microsatellite stability or instability, HER2 or HER2, which is we often associate with breast cancers, KRAS, NRAS status, BRAF mutations. These are all emerging markers and alterations that are being designed chemotherapeutically, and you may be a candidate for these types of markers based on that genetic status. And that's why one of the things here at the University of Pittsburgh is we stress that everybody that has an appendiceal neoplasm, whether it's even low grade, should get molecular testing so we can better understand their disease process and potentially actionable alterations that your oncologist or your surgeon can act on. And certainly, we've seen FDA approvals and for some of these targets, like KRAS inhibitors, have already started to enter the FDA approval market and are being given to certain patients with certain mutations. The same goes with BRAF inhibitors. If you have an MSI high appendiceal neoplasm, you're a candidate for basically the commercials you see on lung cancer when it comes to Keytruda. You can get the same kind of therapy, and that being immunotherapy. And we know that patients do extremely well if they're candidates for immunotherapy and the immunotherapy works overall. So how do you put it all together? I think that it's really important to understand again that it's not just histology, it's the molecular, it's also the tumor markers that are given from the blood-based markers themselves, it's the margins, it's the PCI score that's done by the surgeon. What is your disease burden? And that's where a team is really a focus plan. And to be honest, your biggest advocate also is not only you, but also your surgeon, your oncologist, your pathologist. It's okay to ask questions. I think that's expected. You should be asking questions. It's important for you to understand your body, your cancer, your neoplasm overall. And then from there, you be an active participant when it comes to your treatment. And that's why I really underscore questions to ask. If it's not there in the report, you need to get that information. What's the grade? What's the stage of tumor? What were the margins? What does that pathology report mean for your prognosis? Those are questions you should be asking your physician if it's not apparent. What are the results of your molecular testing? And then what's the next steps thereafter? And I think that that's an important thing that you should really take away when it comes to understanding what you're dealing with when it comes to your disease process, and something that we try to discuss with all of our patients that come to see at University of Pittsburgh Medical Center. With that, I think I'll end as I think I'm pretty much over time or on time, hopefully.
Oh, oh, there's no such thing as overtime. So
Okay.
that this was perfect. Dr. Singhi, this was such a valuable talk. I mean, really, really appreciate you underscoring just the importance of getting the pathology right from the start and how the pathologist is an important member of the team. We did get some advanced questions, so what I'd like to do is just go through those. I do think you did address a lot of these, but we'll just confirm and go through. And then if there are additional questions, we'll go through any questions in the chat, if that's okay.
Absolutely.
Okay. Let's see. Um, if you could just reiterate what is the difference between peritoneal carcinomatosis and PMP?
Yeah, so I think that, unfortunately, the nomenclature has changed, and you often see just people calling, like, let's say it's the radiologists. When they see an implant radiographically, they almost always call it peritoneal carcinomatosis, or the header always just calls peritoneal carcinomatosis. To a pathologist, peritoneal carcinomatosis is when you have a true adenocarcinoma or a goblet cell adenocarcinoma again, where it is now invading in a peritonealized organ. So that meaning outside of the appendix itself. That is true peritoneal carcinomatosis. Pseudomyxoma peritonei is really stunning. It's basically when you have a low-grade appendiceal mucinous neoplasm, for a good example, where it's a non-invasive lesion and it's stuck to different parts of your body with that because of that mucin. That's PMP.
Okay, thank you. Let's see, the goblet cell explanation, I think you covered. Um, and this might be, I guess, curious for the pathologist response to recovery. Is it possible to return to a normal GI function after CRS, HIPEC, and a loss of 20 inches of mostly small intestine?
It's amazing what we can endure without significant portions of our bowel. I've seen many patients that have had a significant CRS that where significant portions of organs, the spleen, portion of your pancreas, portion of your small bowel, large lengths of your small bowel, and your colon have been removed, and those patients still function extremely well. It's really about being proactive and, again, having a positive attitude about this. This is, unfortunate that the CRS had to occur, but we're also trying to cover as much of the disease process as possible and trying to remove it to kind of really hinder the disease from progressing overall. And so, as a pathologist, I'm not as involved in that, but I have certainly seen multiple surgeries that are undergo, and those patients still live a long life.
Thank you. Uh, could you comment on treatment for Lammin when additional surgery is not recommended?
So those are often cases where yeah, so it can be in two scenarios. One is that there's very little disease burden, such that there's no point right now in going in, because one of the things about your surgeon sometimes is if the disease burden is so low, and we know the disease process is slow from understanding your radiology, then it's unlikely that intervening early and more aggressively will help. It could actually hinder. The more times you go in to the body, into the abdominal cavity, and start to resect, you can induce other things, side effects. That could be adhesions. That could just be an inadvertent, unfortunate problem of having surgery multiple times. And so there are times where the disease burden is low and your surgeon chooses not to do anything and will just continue monitoring it as long as there's no changes. But that's where close monitoring based on your surgeon's plan is extremely important. There are other scenarios, unfortunately, where the disease process is too great, where there's too much to remove at this time. However, those patients still could have a fine functioning life itself. Remember, these are implants. Not every implant can cause or needs to be intervened. It's only when that implant really sometimes is causing occlusion of the bowel. Like again, remember your bowel itself, your digestive system is really a pipe. It goes down and basically from up to down, and it just goes through and in different routes. And for the most part, if those implants start to impinge on that pipe, just like the appendix, causing pressure, and that where it could result in perforation or the lack of movement of your normal food and your normal digestive system itself, that's where it needs to be intervened in. So there's going to be multiple scenarios where a surgeon says that there's no need for surgery, unfortunately, at this time, unless there is something where they need to intervene imminently or to help the kind of curb the disease process. But this is all really something that needs to be discussed with your surgeon overall in a personalized manner.
Thank you. Uh, let's see. This question, I think you addressed some of it, but treatment and clinical trials for Lammin with GNAS and KRAS mutations for a patient that's inoperable.
Right. So, so clinical trials certainly are, the unfortunate problem with clinical trials is there's not a lot of them when it comes to appendiceal neoplasms. And I think that's the unfortunate problem lacking. We need to get more, honestly, more attention to pseudomyxoma and appendiceal mucinous neoplasm, especially adenocarcinomas, and understanding, what are ways that we can target these neoplasms better. They're not the same as colon cancer. Unfortunately, they often get our patients that have appendiceal mucinous neoplasms get lumped in with our colon cancer patients when it's a very different disease process overall. And what we need to do, as I had mentioned before, is really we need to study this disease better. GNAS mutations in your normal colon cancer, extremely rare, but extremely common in appendiceal neoplasms. These are truly a different disease process genetically and morphologically. Hence, we need to have trials that are really focused on this disease process. Now, that being said, one thing that we do know about appendiceal neoplasms that I'm looking very forward to is all the new KRAS inhibitors. Over 90% of appendiceal mucinous neoplasms have a KRAS mutation. And there are about 20 different drugs coming down the pipeline, all coming up for FDA approval on different KRAS mutations. So I think everyone is going to be excited, not only those that have appendiceal cancers, but pancreatic cancer, colon cancers that can have KRAS mutations, although much rarer in colon cancer. I think all of this, when it comes to the GI tract, are going to be very interested in seeing where these KRAS inhibitors could potentially be helpful. Unfortunately, there's nothing to target GNAS, but I would say that whenever you see a GNAS mutation, you almost always see a KRAS mutation. So the hope is that these KRAS inhibitors, once they come to the kind of the mainstream clinic, currently they're in different clinical trials, and I will say that almost every clinical trial that opens up with a KRAS inhibitor fills so fast because we have so many different neoplasms. I'm hoping that we start to get something that's more tailored for appendiceal neoplasms to target those and see if we can make a dent in this disease process.
Thank you. I'm going to move over to the questions that showed up in the chat,
Yeah.
and we'll go through those. And so if you did submit an advanced question and still need clarification, then please put your question again in the chat. Okay, you can see that the first one there, and so it's really a question related to genetic testing for children
Oh, I'm sorry.
of this
The one I
patient.
see right now is the first one
Um,
about a poorly
I was
differentiated.
diagnosed in 2021 and have
Okay, yes. And so do you think the testing is okay? So one of the things is that okay. So this is a very specific. So the good thing is MSI high cancers, extremely good candidates for immunotherapy. We've seen cures for immunotherapy when it comes to colon cancer, pancreatic cancer, and appendiceal cancers that are MSI high. And that's one of the reasons why we do universal screening. Every pathologist, everybody in the United States, that's important when it comes to pathology, we screen for MSI testing on every appendiceal neoplasm, or at least if it's not done, it should be done. And that's because we know that even though it's extremely rare to have an MSI high or mismatch repair deficient appendiceal cancer, those patients could respond extremely well to immunotherapy. I would say, unfortunately, it's less than 1% of appendiceal neoplasms have MSI high status, but again, it's a real home run when you have it. Now, we do know that MSI high cancers in general can run in families, and that is a syndrome called Lynch syndrome. Lynch syndrome can be run in families, but sometimes it doesn't. Sometimes it can only be a unique person that has it, and the children don't have it. Now, the pathologist isn't the appropriate person to determine whether your children should get testing or not. Instead, it should be a genetic counselor. The genetic counselor then can consult the pathologist, but the genetic counselor is the person to ask and to discuss this along with, your clinical team on is it appropriate for getting genetic testing for your children. If you have been tested and are not a carrier of Lynch syndrome, then that means the risk of your children having it is nil to none. That being said, again, this is something that you need to discuss with a genetic counselor and to understand the genetics of the disease process and also if this could be a germline association. But understanding why your cancer is MSI high is extremely important, and that understanding where that gene, which gene alteration is associated with it, because that's where the genetic counselor can determine basically the penetrance of that being associated with a syndrome versus not. Now, when it comes to getting insurance, I would say that that is the unfortunate problem that we all know about in the news today when it comes to insurance, getting things covered, and et cetera. Unfortunately, that is a bit of a political issue that we're all trying to understand. I wish it was unique or it was common for everybody to understand what insurance issues occur here in Pittsburgh versus, let's say, in California or in Florida. Every institution, every site, every region is very unique when it comes to insurance and coverage. And unfortunately, here in the United States, we don't have something where we can just say that it's all under the same care and we're all being treated the same. Sadly, I can't say that. There are certain coverages that occur better in certain states versus others. There's certain patients that have different health plans that cover certain things than others. And unfortunately, this is a discussion with your insurance provider and what they cover versus not, and versus what are the out of pocket costs.
Okay, thank you. The next question, is it possible that one pathologist can give another outcome that's different from another. So in this
Yeah.
situation, one was the poorly differentiated and the other moderately differentiated.
So, I mean, I think this is the unfortunate problem is that it's all in the eye of the beholder. I mean, you can think of this as, remember, this is a subjective science. We look under the microscope, we try to put two and two together. We're putting the morphology, but not everything is black and white. There's a lot of gray. And so there can be debate even amongst experts whether it's poorly differentiated versus moderately differentiated. And that's where we're all looking for, and then this slide probably says it best, we're looking for genetic alterations to be more objective, to tell us, okay, what state is it at? And that's one of the reasons why grading changed to kind of reflect the molecular alterations, and where we think that the molecular alterations may be helpful in helping in those gray areas. If you have a SMAD4 or P53, then you are more likely more of a grade 2 versus grade 3 type neoplasm. Unfortunately, the molecular alterations associated with grade 2 and grade 3 are not well delineated. We don't have great genetics for grade 3 neoplasms. And the reason is grade 3 neoplasms often are rare. They're not as common as your modelly differentiated adenos. And so I would say that the high risk mutations that are shown here, P53, SMAD4, ATM, CDKN2A, mTOR, these are in the literature, but they've only been described as a whole for grade 2 and grade 3. We don't have great markers between grade 2 and grade 3 itself. I know that that's an important aspect. We want to know if progression is occurring or not. Is it a poorly differentiated adenocarcinoma or not? But sadly, I think that that's still going to be up to the point where we can try to develop a consensus. But there will be people that have a different way of signing them out as pathologists. And until we get better information, more understanding of the disease process, unfortunately, we're not going to get there yet. We did have whole genome and have DNA results. They added it in the database to give results of Dutch profiles.
Mhm.
Okay, so this is very complex. Whole genome sequencing here in the United States is not covered under US health insurance, and it's not the Association of Molecular Pathologists, which is our governing body here in the United States for molecular testing, does not advocate for whole genome sequencing yet because it's still an early technology. It's not sensitive. And one of the things about sensitivity is that if you have a neoplasm that has very few cells, let's say, it's hard to sequence neoplasms that have very few cells. It's usually easier to sequence to put into a molecular sequencer when there's lots and lots of cellularity. And so right now in the United States, we don't do whole genome sequencing, so I really can't comment on that because the technology is not FDA approved at all here in the United States. But I think that one day it will be. But the whole genome sequencing is looking very interesting because it tells you all of the information. It basically sequences the entire landscape of the genetic alterations associated with the pathology that you have. And I think that'll be very telling. But right now in the United States, we do targeted DNA, like such as KRAS, P53, GNAS, etc. So I think that at this moment in time, we just don't know what to do with whole genome sequencing data.
Okay. Um,
Um, After CRS 1 year ago, how long does Lambda stay stable and what follow-up is recommended? Sadly, I wish we had prognostic biomarkers that can tell you the window of time. And I think that's the challenges with any cancer. Unfortunately, we're still learning, and that time will honestly that'll take more with time as we get more and more patients understanding where they presented, what their molecular alterations are, what their pathology is, what their tumor markers are, what their disease status, PCI score, what is their overall pathology, both from the neoplastic point of view to the patient point of view, like their age, gender, etc. Unfortunately, we don't have the ability to predict how stable something is right now versus follow-up, especially with a disease process as rare as Lamin, as appendiceal mucinous neoplasms. We have gotten to that point for lung cancer or colon cancer, and that's because there's such a higher prevalence. But even those cancers, we're starting to see them in younger individuals, which means that there's an environmental influence too now. And so I think that unfortunately at this moment in time, we have a hard time predicting it. And that's why surveillance is so important and so recommended. And at the time, that's where you have to consult your surgeon, your radiologist, based on the disease process that you have and what their opinion would be and how to follow you. And then what databases are good? Can it be that pathologists in other countries allows? I'm not 100% sure if I understand something about the pathologists in other countries state that a mucinous that has a high PCA poorly differentiated. By definition, if you're grade 3, you're already an adeno. If by definition, if it's called grade 2, you're an adeno. These are typically mucinous adenocarcinomas. If there's no mucin in the adeno, that's something to be concerned about, whether you truly have an appendiceal mucinous adenocarcinoma or something else, like maybe a goblet cell, if it's poorly differentiated. I think that's where some of the pathologists sometimes can get confused. And honestly, that's a challenge for a lot of pathologists is distinguishing a grade 3 cingulate ring cell carcinoma from a goblet cell adenocarcinoma, especially a grade 3 goblet cell adenocarcinoma. Some tricks of the trade for some pathologists is again molecular testing because we know KRAS and GNAS are extremely common in appendiceal mucinous neoplasms versus a goblet cell adenocarcinoma, which they're devoid of the KRAS and GNAS. So that's how I can use that. Unfortunately, there's not a great database, and I think that's sorely needed as well. We need a registry of patients. We need a registry of molecular information. We need honestly a place where people and researchers and clinicians and patients alike can go for advocacy, research, understanding of disease process, and getting together all in one forum to say, okay, these are the things that we need to understand and study, and this is how we're going to tackle them. Right now, I think we're all a bit siloed. We're all doing little projects here and there, trying to get to answers. But I think with a rare disease like this, we need to all come together somehow. But yeah, having a database would be fantastic. How
Mm.
often does the AJCC guidelines get updated? So I'm on the AJCC guidelines, not for the appendix, but for other digestive diseases. And I will tell you that usually, or previously, it was every 3 to 5 years. Now the AJCC recognizes that shouldn't occur. There can be updates to one tumor type versus another. And so now they only occur when there's a significant data update, meaning that we now recognize that there's a new entity. We need to separate neoplasms into different types. There's a benefit from a surgical point of view and staging or grading something. That's when it will get updated. So the AJCC for appendix was updated to the ninth edition for appendix, but I can give you an example for the pancreas. It's currently at the eighth edition. And so the addition now updates will occur in a timely fashion and are not stuck where every organ has to update at the same time, where we're all dependent on every other organ. Where now the appendix, as well as every other organ itself, can now be independently and update as it goes, and it can do it in real time. So if there is something that's truly mature that everyone has had a consensus, and that's usually a community consensus that's in the United States, unfortunately, and it is only it's made for the United States, but typically we also take cues from Europe and from other international colleagues. If there's something that is now changed that we need to update, then it will get updated.
Right. There was another question that doesn't appear in the chat, but who do you think, if you have an opinion on the top three U.S. specialty centers for this disease?
I, I can't comment on that. I'm
Okay.
biased.
Understand. Understand. Um, yeah, I think we got all the questions. Let's see, did we get the research in place for Lamin and any future?
Yeah, so future exciting underpinnings now in the research process, I think will be the KRAS inhibitors.
Mhm.
Honestly, even in the stage of Lamin, they already have KRAS mutations. We know that's a true driver. We understand that day in and day out from the research over 2 decades of research of understanding lamins and the progression model that KRAS and GNAS are their early alterations. And if we can turn off the initiating driver alteration, the gene mutation that's driving the bus, the school bus with P53 SMAD4 as passengers, if we can turn that driver off, we can make him stop, maybe we can make the neoplasm stop. And so I'm hoping that will be the key. Now, I don't want to put all our eggs in one basket. And so that's why we do significant amounts of testing. I mentioned lots of different genes like HER2, BRAF testing, other things are going on. And so it's not like we're all just focused on KRAS. There's lots of different things coming down the pipeline. Things that you might hear about are different antibody drug conjugates that are coming through, meaning that these are antibodies that are targeting a tumor, that stick to the tumor, and that are basically a smart bomb, is what we call it. And basically, that these antibodies have a chemotherapy regimen hooked up to them, so that once they target the tumor, they push the chemotherapy only into the tumor so that it can decrease the side effects and cause directed chemotherapy to that cancer. So those are things that ADCs, is what we call them, antibody drug conjugates, those are things that we're getting very excited about. But they are unfortunately years away before they're mature enough to do some standard practice.
That is very exciting.
Yeah.
Yes. I think we could probably be here all day. I mean, this was so educational and I'm going to use the word empowering for us patients with your emphasis on us making sure we know the answers to those questions, that we understand our pathologies and that all the molecular testing is done.
Yeah, I think there's so much that a patient should understand because I wish I could say that every physician that you have can take the time to do so much, understand every part of you, your history, and not only your history, but your family's history, your day in, day in out. And really, it's really important at this time, in this stage, in this day, that really a patient empowers themselves with understanding every aspect. It's okay to ask questions. Don't feel like you can't ask questions. And even to the pathologist. I mean, there's a phone number in every pathology report to discuss your pathology report with the pathologist signing it out. And I would encourage you to do so if there are questions about it. Or ask questions to your surgeon, like, what does this mean and how he or she is going to change management for you specifically? And then what are your options going forward? And I think that's extremely important. And if you don't ask questions, you just don't know.
You know, that really is great advice. I don't think we often think to connect with the pathologist. Usually they're names or you're just a report. And so, having that ability to hear it from the pathologist,
Yeah.
I think would be very educational for us patients.
Yeah, and then I think that the most demystifying issue, unfortunately, is dealing with the molecular report. It's just a lot of names, and unfortunately, our understanding is limited in certain physicians. And so, definitely asking a pathologist about what their molecular report means can mean a significant impact sometimes. And so, certainly ask questions. Yeah.
Yeah. Well, Dr. Singhi, we cannot thank you enough
Yeah,
for
thank you.
spending time with us on Saturday here and all the information and the great presentation and responding to all of our questions. So greatly appreciate it.
Thank you for having me. I appreciate it. Have a good
Thank you.
weekend and happy
Yes, you
holidays.
too. Yes, same to you. Thank you. And for everyone else that joined, thank you so much for joining us today. We are officially on Hope Zoom break until January 7th, but as everyone knows, we're always here. So don't hesitate to reach out to us.
Thank you again.
Thank you, Dr.
Thank
Singhi. That was
you.
excellent.
Yes.
Excellent.